So, we will now continue with space infections. We have already discussed about the primary and the secondary odontogenic spaces. Let us now move on to the deeper neck spaces. The first space that we will be discussing about is the lateral pharyngeal space. Okay, so the boundaries of the lateral pharyngeal space are pterygomandibular raphe anteriorly, posteriorly, the prevertebral fascia, laterally, the fascia covering the medial pterygoid muscle, parotid, and the mandible, medially, the buccopharyngeal fascia on the lateral surface of the superior constrictor muscle. The styloid process divides the space into anterior muscular and posterior vascular compartment. It is an inverted cone or pyramid shaped space. Its base is at sphenoid bone, excuse me, and the apex is at hyoid bone. See, the space can be understood through this picture. I'll quickly revise the anatomy again. This is a transverse section. See, this is the platysma muscle that we were discussing. Okay, this muscle, these are the two sections of the mandibular ramus. This muscle is the mylohyoid muscle, the most important muscle in odontogenic spaces. Kind of. These two are the anterior belly of the digastric muscles, and between the two anterior bellies would lie the submental space, as we have been discussing through the beginning of this lecture. Okay. Now, between the anterior and the posterior belly of the digastric will be the submandibular space, which can be appreciated here. है ना? इसमें the posterior belly of the digastric is not, मतलब इस section में नहीं दिखता है. This is the submandibular space which will lie below the mylohyoid muscle. Okay, and this is the sublingual space which lies above the mylohyoid muscle. Fine. This is the tongue. These are the two important tongue muscles. This is the genohyoid muscle. This is the genioglossus muscle on both sides, genioglossus muscle and the genohyoid muscle. Fine. Now, this is the tongue, the pink colored area. This is the tongue. This is the airway. Okay, this is the airway. Now, coming on to this region. This is the mandible. On the medial surface lies the medial pterygoid muscle. Okay, and on the lateral surface lies the masseter muscle. Fine. This is the mandibular region. This is the medial pterygoid muscle. This is the masseter muscle. Posteriorly lies the parotid gland. Fine. Now, this area behind the tongue is the airway. This is the superior constrictor muscle, the superior pharyngeal constrictor muscle, and this is a layer of the buccopharyngeal fascia. Fine. Now, as we read yesterday, pterygomandibular space would be the space between the medial pterygoid muscle and the lingual surface of the mandible. Okay, so this is the pterygomandibular space. Mesenteric space would be the space between the masseter muscle and the lateral surface of the mandible. So this space between these two would be the mesenteric space. Okay, and this is the outermost layer, which is obviously the skin. Now, since we are discussing about The lateral pharyngeal space is roughly located here. Okay, this is the lateral pharyngeal space. It is divided by stelloid process into two regions. Okay, fine. Now, this is the prevertebral fascia. This is the alar fascia. And the space between the prevertebral fascia and the alar fascia is the danger space. Okay, as depicted here. Okay. Lateral pharyngeal space also contains the carotid sheath, which encompasses the carotid artery, the internal jugular vein, and the vagus nerve. The carotid artery, the internal jugular vein, and the vagus nerve, as can be seen here. Okay. So now, since we have gone through this diagram, let us revise the boundaries of the lateral pharyngeal space again. The pterygomandibular raphe, which would be somewhere over here, okay? Then the prevertebral fascia, okay? Prevertebral fascia, I told you, the prevertebral fascia. Fine. Another bond boundary would be this, okay? Laterally, the fascia covering the medial pterygoid muscle, parotid, and the mandible. Laterally, the boundary would be this, okay? Anteriorly, pterygomandibular raphe. Posteriorly, the prevertebral fascia. Laterally, the fascia covering the parotid gland, the medial surface of the ramus of the mandible. Yogi lateral boundary. The medial boundary would be the buccopharyngeal fascia and the superior constrictor muscle, okay? Understood? Medially, the buccopharyngeal fascia and on the lateral surface of the superior constrictor muscle. So, the stelloid process will divide it into two parts. The anterior compartment would contain fat, muscle, lymph nodes, and connective tissue. The posterior compartment, as we discussed, would lie somewhere here and it encompasses the carotid sheath, which contains the carotid artery, the internal jugular vein, the vagus nerve, and the cranial nerves. Okay, so the etiology of this space involvement is infected mandibular third molars, tonsillar infections, pharyngitis, and the parotitis. The spread of the infection through this space is to the retropharyngeal space and the peritonsillar space. Okay. Now, the symptoms when anterior compartment of the lateral pharyngeal space is involved are trismus, induration, and swelling at the angle of the jaw, fever, and pharyngeal bulging. The symptoms of the posterior compartment involvement, because it contains the vital structures, would be something specific, which will include neurological involvement, peritonsillar pillar elevation, thrombosis of the IJV, and erosion of the carotid vessels. Okay, this was the lateral pharyngeal space. Now coming on to the retropharyngeal space. It lies posteromedial to the lateral pharyngeal space and anterior to the prevertebral space. Now appreciate it in this picture. It lies posteromedial. This is the medial area. This is the lateral pharyngeal space. The retropharyngeal space will lie posteromedial. See, it is medial, it is posterior as well. It will lie posteromedial to the lateral pharyngeal space and it would be anterior to the prevertebral space. Okay. Boundaries. Anteriorly, the posterior pharyngeal wall. Posteriorly, the prevertebral fascia. Please appreciate. Anterior boundaries of this space is the buccopharyngeal fascia. Posterior boundary is the prevertebral fascia. Fine. Superiorly, the skull base. Inferiorly, the infection, since it reaches the reaches to the mediastinum and causes mediastinitis. So the inferior boundary of the retropharyngeal space would be mediastinum, and laterally, of course, it is bounded by the lateral pharyngeal space. So it all seems very simple when we understand it through the diagrams. Fine. This is the retropharyngeal space. Its boundaries are the buccopharyngeal fascia, the prevertebral fascia, and superiorly the skull base, inferiorly the mediastinum, and laterally this lateral pharyngeal space. Fine. Now, the clinical features of its involvement are the stiffness of the neck, the dyspnea, the dysphagia, bulging of the posterior pharyngeal wall. The complications include airway obstruction, aspiration pneumonia, acute mediastinitis, and the spread to danger spaces. Now, coming on to the last space, which is the prevertebral space. It is the space between the two layers of prevertebral fascia, the alar and the prevertebral layers. It extends from the skull base superiorly to the diaphragm inferiorly, and mediastinitis is a concern when this space is involved, which is similar to the retropharyngeal space infection. So, where is the prevertebral space? This is the prevertebral space. Okay, fine. Now, coming on to the potential pathways of extension of deep facial space infections of the head and neck. As we have been discussing throughout this lecture, the maxillary periapical abscesses can lead to involvement of the buccal space, to involvement of the canine space, to involvement of the infraorbital space, and the infection can spread until the orbit. Now, the mandibular periapical abscesses can lead to the formation of parotid space infection, masticator space infections, submandibular and sublingual space involvement, direct involvement of the lateral pharyngeal spaces, uh, submandibular and sublingual space can also lead to lateral pharyngeal space infection. Similarly, masticatory spaces, which are namely the mesenteric, pterygoid, and the superficial and deep temporal spaces, can also lead to lateral pharyngeal space infection. Since, as I told in the beginning of the lecture and in between also, that all the spaces are interconnected. Lateral pharyngeal space infections can then subsequently lead to involvement of the carotid sheath, and the infection can spread up to the cranium. The lateral pharyngeal space can also spread the infection to the retropharyngeal space, and then subsequently through both the pathways, through the involvement of carotid sheath or through the involvement of retropharyngeal space, there would be the infection in the mediastinum, and it will lead to mediastinitis. Okay. Now, coming on to the most important topic with regards to the examination. It is the Ludwig's angina. It is named after German physician who described the seriousness of the order in 1836. The angina word comes from Latin word angere, which means to strangle. What is Ludwig's angina exactly? It is the bilateral brawny cellulitis of the submental, sublingual, and submandibular spaces. Okay. So, what are the key points to remember? It is a brawny cellulitis, and it occurs because of the involvement. The most important thing to be considered is bilateral involvement of submental, sublingual, and the submandibular spaces. Now, coming on to etiology, uh, the most common reasons that have been discussed in literature regarding the etiology of Ludwig's angina are the periapical or the periodontal infections of the lower molars, the pericoronal infections of the third molars, traumatic injuries and infected lesions, osteomyelitis of mandible, cysts or tumors in the third molar region. Now, it is considered to be more prevalent in immunocompromised patients. And what are these states? The patients with diabetes mellitus, the patients who have undergone organ transplantation, the patients with acquired immunodeficiency syndrome, the patients with aplastic anemia. This is what a patient of Ludwig's angina looks like. And classically, the presentation which we discussed in the definition of Ludwig's angina, it is the bilateral brawny swelling involving the submental, submandibular, and the sublingual spaces. What are the clinical features? There is massive swelling in the neck, which often extends till the clavicle. Okay. which often extends till the clavicle. There, the involvement of the sublingual space results in elevation of the tongue, posterior enlargement of the tongue, and the protrusion of the tongue, which causes the tongue to become woody, and this swollen woody tongue can compromise the airway. What are the clinical features? Because of involvement of submandibular space, there is enlargement of the area, there is tenderness of neck above the hyoid bone, there is pain in neck and floor of the mouth, there is restricted neck movement, which leads to a pattern which is similar to bull neck. There is dysphagia, dysphonia, drooling, and sore throat. Involvement of the lateral pharyngeal space may also occur, and then it will lead to respiratory obstruction secondary to laryngeal edema, tachypnea, dyspnea, tachycardia, and patient needs to maintain the erect position to breathe. Now, coming on to treatment and prognosis. The treatment mainly centers around four activities. The first and foremost being the maintenance of airway, then the incision and drainage, antibiotic therapy, and elimination of original focus of inflammation. So, these are the goals that our treatment should center around. Now, if signs or symptoms of impending airway obstruction are evident, then the patient should be immediately taken up for fiber optic nasotracheal intubation, oral intubation if possible, tracheostomy or cricothyroidotomy. Any three of these things must be done, whichever is possible. Antibiotic therapy mainly includes administering high dose of penicillin, or in cases of penicillin sensitive patients, we can administer clindamycin or chloramphenicol. Antibiotic medication is adjusted according to patient's response, plus culture if the infection is not resolving. If the infection is not resolving, then we send the samples for pus culture and antibiotic sensitivity, and the results of this test would then further modify the antibiotic regime we are following for the patient. Fine. And in the infection remains, diffuse indurated bronchi, surgical intervention is then performed at the discretion of the clinician, and it is often governed by patient's response to non-invasive therapy. So this slide means that if it is the initial stage of infection, it is likely that it may respond only to antibiotic therapy, but in majority of the cases, we have to go for surgical incision and drainage. This is a patient in which the drainage has been performed and the drains for maintaining the patency have been inserted. Complications of Ludwig's angina include pericarditis, pneumonia, mediastinitis, sepsis, empyema, or respiratory obstruction. Coming on to the second most important severe sequelae of odontogenic infection, it is the cavernous sinus thrombosis. A cavernous sinus thrombosis results from an odontogenic infection which has spread through the facial veins, specifically the pterygoid plexus of veins, because they lack valves. And the infection then travels upwards towards the cavernous sinus via the ophthalmic veins, ultimately reaching the sinus where it can form a clot due to inflammatory response triggered by the infection. This pathway is most commonly seen with infections in the upper maxillary teeth. Now, the clinical presentation would be edematous periorbital enlargement with involvement of eyelids and conjunctiva. There will be pain over the eye and along the distribution of ophthalmic and maxillary branches of the trigeminal nerve. In cases involving the canine space, the following features would be evident: induration and swelling of the adjacent forehead and nose. The swelling can extend up to the middle aspect of the eye and the periorbital area. There is protrusion and fixation of the eyeball, pupillary dilatation, lacrimation, photophobia, loss of vision. Any of these features may be present. The treatment and prognosis again is surgical drainage and high dose antibiotic medication similar to those administered for patients with Ludwig's angina. However, in many cases, we would have to go for higher antibiotics, which are piperacillin and tazobactam combinations, or administration of vancomycin after we have received the pus and culture sensitivity results. Now, this diagram is summarizing the potential pathways of spread of odontogenic infections, which we have been learning throughout this lecture. If there is masticator space infection, the infection spreads to the lateral pharyngeal space, then to the retropharyngeal space, and then to the danger space, causing mediastinitis. Likewise, submandibular space infections, submental space infections, both the submental, submandibular, and the sublingual spaces can involve the contralateral spaces. Okay, and then Ludwig's angina can occur, which is obviously the bilateral involvement of the three spaces, which can lead to airway obstruction. Canine space infection can lead to infraorbital space infection. The infection can spread via the angular veins superiorly and can cause cavernous sinus thrombosis. The management of odontogenic infections, the goals are first and foremost the protection of the airway through intubation or tracheostomy, then establishing surgical drainage through incision and drainage, medical support of the patient in the form of antibiotics and other drugs, identification of etiological bacteria in recurrent, non-resolving, or systemic odontogenic infections through bacteria culture and antibiotic sensitivity, and then selection or modification of the appropriate antibiotic therapy. Let us briefly discuss Hilton's method of incision and drainage. So, how do we proceed while performing incision and drainage in patients with odontogenic space infections? Topical anesthesia is administered. It can be spray or infiltration. Stab incision is given through the skin and subcutaneous tissue. If the pus is not encountered, further deepening of the surgical site is done with sinus forceps. Abscess cavity is entered and forceps is opened in direction parallel to the vital structures. Remember, we take care not to harm any of the vital structures. Explore the entire cavity for additional loculi. Cavity is irrigated copiously with saline and antiseptic solutions. The drain is placed and dressing is done, and dressing is repeated in a very timely manner until the infection has subsided. Let us now discuss the drainage of these spaces. The canine, the sublingual, and the vestibular abscesses, they are drained via placing, they can be drained via placing intraoral incisions. The mesenteric, pterygomandibular, buccal, and lateral pharyngeal abscesses can be drained with combination of intraoral and extraoral drainages. Whereas temporal, submandibular, submental, retropharyngeal, and parotid spaces, they usually require extraoral incision and drainage. This diagram depicts the incisions that we usually give for draining the abscesses. This incision will drain the temporal space infection. This incision below the chin will drain the submental space infection. This incision, which we discussed in detail while we were discussing submandibular space, will drain the submandibular space infection. Now, this incision would drain submandibular, submesenteric, and pterygomandibular space infections. These incisions deeper in the neck would drain the lateral pharyngeal space and the upper portion of the retropharyngeal space infections. The lowest most incision is specifically for retropharyngeal space and carotid sheath infections. Many a times multiple spaces are involved, and in severe cases we have to give multiple incisions. Again, these are the standard extraoral incisions that are given to drain the infections. These are the intraoral incision sites. If there is a canine space infection, we would give this vestibular incision above the canine and the premolar tooth. For the palatal space infection, this incision is given. Peritonsillar space infection, this incision is given. Sublingual space, we discussed, can be drained intraorally through this incision placed in the lingual vestibule, but it does not establish a dependent drainage. Okay. This is classically a patient of Ludwig's angina, whereby you can appreciate bilateral swelling of the three spaces, submental, sublingual, and submandibular space. This is a hard, brawny swelling. The patient is unable to close the mouth. The tongue you can appreciate is hard, and it has elevated the floor of the mouth. The incision that is followed in cases of submandibular space infection. The drainage of the pus. Blunt finger dissection is utilized to ensure that the entire submandibular and sublingual spaces have been explored. And after that we insert drains. These are the references which I followed while making this presentation. The standard textbooks. I've included one article of mine also, which has been published in our National Journal of Maxillofacial and Oral Surgery. Thank you. Hope you understood the topic, and it will now enable you to diagnose and treat the odontogenic space infections. Thank you so much. Have a nice day.